So without further ado, may I introduce Dr. Liz Lightstone.
Good afternoon. I'm very conscious it's very late in the day and dark. Oh, it's lovely out there, I'm pleased to know. So and also apparently we're taking questions here, we're not having a Q&A, so I sort of timed this to fill the time, so I might go a little quickly, but you can interrupt and you can certainly ask questions at the end. I advise lots of companies about clinical trials of drug science, and those are companies I've been advising, some of my disclosures. What I want to cover this afternoon is really what is lupus kidney disease. I'm a kidney physician. I work at the Hammersmith Hospital, and we have the Imperial Lupus Centre there now, and I work with colleagues. We have joint clinic, rheumatology and renal. But I've had an interest in lupus and lupus kidney disease since I became a consultant too many years ago. So I want to talk about what is lupus kidney disease, because you get sent to me and I bang on about what's wrong with your kidneys, and actually often you need a little step back. How do we diagnose it? And I'll spend a little time on that. What I think is standard treatment at the moment. And then I'm going to a little bit about new approaches, and I'm unashamedly going to talk about the work we've done, and then talk about special cases, but really just focusing on pregnancy and lupus. So what is lupus kidney disease? And I'm not going to go through this in any detail whatsoever, but essentially your immune systems are playing up. Our immune systems have evolved over millions of years essentially to deal with infection. That's what they're there to do, and they're very adaptable at doing it. But along the way, sometimes things go wrong, and the lymphocytes, which are part of your white cells, and other cells in the white cells, the macrophages, talk to each other, produce, can have effects and produce antibodies which are produced by B cells that can damage one's cell. In lupus kidney disease, this is a glomerulus, which I'm going to tell you a bit more about in a moment, antibodies, complexes of antibodies and protein antigens that they're recognising, and cells can all get into the glomerulus and cause damage. And that is what is lupus kidney disease. But essentially, it's a sort of final part of abnormalities of the immune system. So most of the treatment is designed to dampen down the immune system. Okay, how do I do next? Okay. So kidney involvement is common. And at presentation, let alone later on, about 40 to 60% of adults will have kidney disease, and even more if you present in childhood, up to 80%. And it's much, much more common in non-white individuals. So people of African descent, people of Hispanic descent, everybody who's non-North European white. And it's much more common, as you know, in women, because lupus is more common in women, but men do get lupus. So if you look at ethnicity and the percentage affected, you will see the most commonly affected are those of African descent, and it's much more likely to cause renal failure in those people. So that's a real problem, and that might be partly a genetic disposition, and a genetic disposition getting end-stage renal failure because you're of African descent and nothing to do with your lupus. Put the two together, and that's a bad combination. And it might also be to do with differences in response to treatment. So I will get to that later. So how do we diagnose it? Almost nobody ever comes to tell me I've got a problem with my kidneys, doctor, because most of it is asymptomatic from your point of view. And it's why every time you go to your rheumatologist or your nephrologist, I hope they are dipping your urine, because the biggest clue is in the urine. If you have protein urine, some of you who have heavy protein urine will notice your urine gets frothy. And actually when you're used to this and you relax, you will know, you'll say, oh, my urine's gone frothy, and then you'll come and tell me you've got kidney disease. But usually you haven't noticed it. And so we look for protein number 6 and we look for blood. And of course blood is problematic because women have periods, it's very common to have a little bit of blood in the urine. But a change, if you have none, and then you've got some, that worries us. And if you've got protein that's increasing or wasn't there and is present, that worries us. And now we send off the urine to quantitate the amount, and we monitor that quantity. None of you should be being asked to do 24-hour urine still. If you're still lugging around big bottles for your clinical appointments, you need to get your doctors into the 21st century and do it on one urine sample. Okay, and then we measure kidney function, and the thing you'll hear us talk about is the creatinine. It's an imperfect measure of kidney function because it's affected by your muscle mass, it's affected by if you have steak for breakfast, your creatinine will go up. If you're a tiny vegan woman who eats very little protein, then your normal creatinine should be much lower than a big beefy bloke who goes down to the gym every day. So we plug the creatinine into an equation these days and get an estimate of kidney function. And the other thing we look at is the albumin. Albumin is one of the main proteins in the blood. If you're leaking a lot of protein from your kidney, your albumin goes down. So we monitor that as well. And we monitor the markers of lupus activity, particularly double-stranded DNA antibodies, which you may have heard of, and complement. Complement gets consumed in lupus and it goes down when you're active. And if David Eisenberg was giving this talk, he'd say if your DNA antibodies going up and your complement's falling, be very afraid. And what we are, we're very afraid. We don't treat them, but we bring you back and see you more often because it can herald a flare. And then what we really have to do to diagnose what's going on is doing a kidney biopsy. And I apologise to all of you if I'm teaching my grandmothers and grandfathers to suck eggs, but these are your kidneys. They sit here, they sit quite far back, and this is what a kidney looks like if you do a cross-section through it. And the outer bit is where all the fun goes on. So the outer bit is full of what are called glomeruli, which form into nephrons, they form into tubules. I'll show you a picture in a moment. And all the activity that you need to make urine, essentially, which is the kidney sits there, it filters the blood, and it sorts out your volume. So when your kidneys don't work, you often can get overloaded with fluid. It's like a bath, you fill up and you can't empty that fluid. Sometimes they actually leak too much fluid. And also they filter out a lot of toxins. So when they're not working, a lot of stuff builds up in your body. And we measure creatinine because that goes up and is cleared pretty quickly by the kidney normally. And all that goes on there, and then the urine filters out here and comes down into ureter, which goes down to your bladder. That's the first bit of your anatomy lesson today. The next bit, we do a biopsy. You never get to see the biopsies. They're the most beautiful things. We have a biopsy meeting every week at the Hammersmith, and I love looking at them. And I'll try and impart some of my enthusiasm for them. So we take a tiny sample of your kidney. We don't actually take them up there. We normally take them from there. Kidneys move when you breathe, they go up and down. And we normally go for the left because it's lower. The right one, there's a large organ called the liver, which you don't really want to go near. You have to put a bit near the ribs. The left one's lower, so we normally go for the lower pole of your left kidney. And we're taking a tiny sample. So in here, there are in each kidney probably about 500,000 glomeruli, and on a good day, we'll get about 20 of them in a biopsy. So we're looking to very small, but we believe highly representative sample of what's going in your kidney. And the glomerulus is this beautiful thing that's essentially a very fine blood vessel, and the blood comes in and it's filtered, and there's a membrane, and across the membrane comes what becomes urine, out in this space, out down into these tubules. It's a very complex little bit of machinery, and it's very precious. We also look for the bits in between the glomeruli because we want to see if there's chronic damage, because we can't undo chronic damage, but we can undo inflammation. And the patterns we look for in the kidney, this is quite technical, but it's really where your antibodies end up in the kidney. And depending whether they're on the blood side of that nice little loop, or whether they're on the other side, and they have specific names, subendothelial, subepithelial, will depend on the pattern of inflammation in the kidney and what diagnosis we give you. So this is just, you can see why I think it's so useful. This is what we call membranous. This is when there's lots of antibodies deposited on the outside of the capillary loops, often associated with a lot of protein, can be very troublesome to you, generally has a relatively good prognosis. And when we look at really high power, we see those dark blobs shouldn't be there. They're all on the outside of that loop, and they're the deposits that go with membranous. The more worrying ones are when we get loads of extra cells in the glomerulus because there's inflammation, because the antibodies are depositing on the blood side of the capillary loops. And depending on how many of those glomeruli are involved, whether it's more than 50% or fewer than 50%, it's a class 3 or class 4. And you've probably seen those on your letters. You have a class 3 lupus nephritis, you have a class 4 lupus nephritis. And this is what we're looking at. Now, I don't want to bring in a dismal note at the end of the day, but it is important to note, and I think it's one of the problems I have when I'm talking to people in the clinic, this is not a benign condition. Untreated, we don't see untreated people generally. We know from historical data, in 1964, if you got lupus nephritis, and this was the first description by a chap called Apollo, they were all chaps in those days. What they saw was that if you have a particular pattern with all those extra cells, you were likely to go into renal failure, and those patients all died. Because remember, in 1964, nobody got dialyzed, and there was a routine transplantation. We have moved on, but this is the natural history, and I think that gets forgotten. We do ask you to take drugs that you may not like, but what we're trying to do is prevent renal failure, and that's what drives me, and that's why I sit there banging on about the treatment. We still have patients end up in needing renal replacement therapy. Apologies for the abbreviations. This is comparing 3 groups. This is the UCH cohort that David Eisenberg has looked at over 30 years. We've been looking at people who've gone on mycophenolate for a long time. And 8% of our patients over 5 years still need dialysis. Now, if I was being brutal, and I looked at that list and we're in the process of looking at, I would say that 80% of those patients who end up on dialysis never took the medications. And that's a difficulty. It's a difficulty for me, and I don't know how to address it. It's a difficulty to have a discussion with people who come to see you, because there's all sorts of reasons why people don't take medications. And I'm not for a moment suggesting they don't have side effects, and there may be very good reasons, but it is a problem. And if you don't take the medications, the treatment can't work. Sometimes it doesn't work even when you do take medications. I'm not doing a blame game here, but it is, I would say, my most problematic bit in what I do. So I don't know that. Okay. What we do know is it's very important to get people to respond, and flares are bad. So we want to get people into what we call remission, so with no proteinuria ID or minimal proteinuria, no blood in their urine, normal kidney function, and if you can stay in that position and not flare, then you're going to do well over time. And this is just a summary of some studies that looked at that, and what's been very important in recent times is that we're beginning to recognise the things that predict early what's going to do well or badly long term. So if you have protein in your urine and it's got down to 50% of what it was by 6 months, 10 years down the line, you're going to be doing much better than if we hadn't achieved that. And that's very important when we're thinking about, is this treatment working or not? Because we can't, much as I would like to do a heart on a weekly basis, we can't. So we have to work on the markers that we have, and proteinuria is our best one at the moment. So what's standard treatment? Well, what do we want? If you think about standard treatment, what do we want? We want rational targeted therapy that treats the problems that are causing the disease, the pathophysiology, and which induces a remission, a good lasting response, and prevents flares. That's the ideal. We want things that ideally don't treat everything else and make you ill, etc., etc. We want targeted therapy. And we need to know those predictors of good response and poor response. We're getting better at that. We need to know what are the best combinations. But equally, we're going to be treating you for a long time. So actually, we need to minimise treatment-related toxicities. And here I begin my bias. We need to get rid of the steroids. I don't feel that I'll be pushing at a door here. And we need to improve adherence, as I've already said, because we've got to work hand in hand and find treatments that suit the individuals we're looking after. And if people are doing so well, which is what we want them to long term, then it's got to be with quality of life and improve survival, and I would argue that involves getting rid of the steroids, improving adherence, and very importantly for a lot of patients I see, facilitating good pregnancies. We're 14 years into the 21st century. What do we have in the UK? There are only 3 drugs licensed for treatment of lupus nephritis in this country: steroids, aspirin, and hydroxychloroquine. Hydroxychloroquine is a wonderful drug, so I'm not knocking it, but it doesn't specifically treat renal disease. Everything I use on a daily basis is not licensed for use. Cyclophosphamide, azathioprine, mycophenolate mofetil, calcium inhibitors, cyclosporin, and rituximab, they are not licensed for use. So we're all working off license. I'm sure many of you have been on these treatments. This group tend to be called cytotoxics. They are a form of chemotherapy. We're generally using them in very low doses compared to what you would use in cancer, but people get a little anxious when they hear the word chemo. But nurses have to be trained to administer them. And rituximab and drugs like that are called biologics. They're antibodies that have been produced, and they now have this generalised rate of biologics. So I don't want you to look at any detail here, but there have been a lot of studies on how to treat lupus nephritis. In 1951, steroids were introduced. And much as I will spend the rest of the talk knocking steroids, they were transforming. There was no treatment for lupus before then, or lupus nephritis, and they were absolutely transforming. And those of you who've had them know they're fantastic for joint pains, they make you feel better acutely. They do have a role, and I'm not saying they don't have any role. And I certainly don't want anyone who's been on the long term going home and just stopping them. That's a very bad plan. But they then introduced other drugs because they realised quite early on there were lots of side effects, and they wanted steroid-sparing agents, and they weren't getting enough of a response. And these early studies, from the 1950s to 1975, there were consistent themes coming up. Steroids were less effective and the disease was less controlled when used on their own. Once you added the cytotoxics, remember back then everything was bigger dose. They had none of the sort of sophistication that we have now about dosing. They were more effective, but there was a much greater increased risk of infections. And then it went on, and there were more trials, particularly using cyclophosphamide in a different way, giving it intravenously, because that was shown to be as effective, but there was less toxicity because you were using much lower doses. So most of us use cyclophosphamide as pulses over time. And methylprednisolone, which is high-dose steroid given intravenously, and for some conditions intramuscularly, also has a very good role. It's fast and dirty and doesn't have a lot of the long-term problems of oral steroids. But again, steroids, not so good on their own, cytotoxics, efficacious, but toxicity, less toxicity with intravenous. Now, it's all got rather more professional in the 21st century. I haven't got time to show you the details of those early trials, but people used to be admitted. There was one trial with 17 patients. They were all admitted for 10 weeks for the entire trial. That doesn't happen. You'll be pleased to know. There have been a lot of trials in the 21st century. There's been a real mixed bag results. They have changed practice. They've often been very well designed trials. But they've all included steroids, and often in quite high dose, and there's been no systematic attempt through any of them, except one or two we'll talk about, to define the correct dose of steroids, the duration of steroids, and how to wean the steroids. There has been some huge disappointments. We all thought that biologics, rituximab and the like, would solve lupus nephritis, and the trials that have been done to date have all been negative. Belimumab, you'll wave back at me, is a positive trial, but that wasn't for lupus nephritis. There's a lupus nephritis trial going on now. But they all added on the biologic to steroids and MMF or cyclophosphamide. My argument is they need to get rid of the steroids and use the biologics instead rather than as add-on. Then they may see the difference. With all those tests, with all those trials, there have been 3 guidelines published in 2012 on what to do with lupus nephritis. Remember, guidelines can only deal with the evidence that's there. They don't look forward, they look backwards. And they're a bit disappointing in many ways because what they do, they grade the evidence in the literature. And 1A, which is what we all want, is like getting gold star, it means there's 2 randomised controlled trials which have shown superiority of the drug and definite benefit. 1B means there's probably been one that's shown benefit and there's some other evidence. Once you get down to 2D, actually the data could be as far from the truth as you imagine because it's weak anecdotal evidence. And if you look at just one of these guidelines, they've got 26 recommendations. There are only 2 1A recommendations. Ironically, they are use steroids, which I would argue is very little evidence for, and don't use nasty drugs in pregnancy. There are 2 1B, which you start with cyclophosphamide or mycophenolate mofetil, which is what almost all of us will do now. And there are 15 2D, which essentially is you can do what you like. And they suggest using rituximab when things haven't gone well. So that's a bit of a gap in the evidence base. But what do most of us do, and what do most units do? They base it on these 2 studies. The Lupus trial, which was a European trial, mostly done in white patients. This regimen has very recently been used in a negative trial of a drug called abatacept in a population including a lot of African Americans. And although the abatacept didn't show any benefit, it did show very nicely that the Lupus regimen worked very well in patients of African descent. So that's very important data that's very recent. But this was important because it showed low-dose cyclophosphamide, so 3 grams over 3 months, was as effective as the old high-dose regimen over 6 months. And they've got 10-year follow-up and longer. So that managed to push back the total dose of cyclophosphamide in your first go to 3 grams, which is relatively little. And the other trial was actually a failed trial. It set out to show that mycophenolate was superior to cyclophosphamide. Excuse me, my acronyms, I thought I got rid of them, but you don't see them, you realise. But mycophenolate wasn't superior, but we've all interpreted the data showing it's as good as, and it is probably better in African Americans, so that, again, that recent trial may change that. And it's as good for class 3 and class 4 as class 5, and these are both steroid-based regimens. So then you have to sit there and say, well, what would you prefer? Well, they've both got their problems. Cyclophosphamide, the newer regimens use much lower doses, so I'm less concerned about long-term toxicity. There is a toxicity with long-term high-dose cyclophosphamide, but you're talking about 30 grams, and the Lupus regimen is 3 grams. It is intravenous every 2 weeks, so I like it because I know you've got it. And then you switch to mycophenolate or azathioprine. It can reduce fertility. Cyclophosphamide can reduce fertility. It's dose-related and age-related, so it's much less likely to cause infertility in an 18-year-old than it is in a 35-year-old. And you must not get pregnant while you're taking it because it is teratogenic. It will very likely to cause abnormalities in the baby. So you mustn't get pregnant with cyclosamide. MMF, and the reason why we were all so keen on it, does not cause infertility. It's tablet-based. You have to take it every day, twice a day. It can cause gastrointestinal upset, and I've certainly seen MMF face. There's one woman I can think of who used to come and say, "I can't bear it," and I ignored her for quite a long time. When I finally switched it was transforming. So she definitely had MMF face, but most people tolerate it. We start low dose and build up. It does not affect fertility. Great, but it is teratogenic. And you should not be on it when you get pregnant. And that data has come out relatively in the last few years, and the advice must be you must use contraception and you must not be taking MMF when you conceive. So they've both got problems, but I will come back at the end to why you shouldn't be getting pregnant when you're needing these anyway. There is positive trial data about what to do in the long term. When when you've got into remission, you need maintenance treatment, you need long-term treatment. And the ARMS trial, which didn't show the benefit of MMF over cyclosamide, showed a very definite benefit of MMF over azathioprine of being, so this is a slightly complicated way of saying it, probability of being event-free. Whatever you look at, doubling creatinine, flares, whatever, MMF was better. There's a separate maintenance trial done with the Lupus regimen, and MMF and azathioprine are equivalent. That's very useful to know, because when you want to get pregnant, we switch you to azathioprine. But I generally keep people on MMF at a slightly lower dose. Now this is the big problem I have, or not I have, but people who come to me, particularly when they first come to me, because there is this sort of nasty sinking in. This is not a short-term condition. You in this room will know this. Response can take months. The longer you're on treatment, the less likely you are to flare, and flares are bad, so we like long-term treatment. So when I tell my patients from the outset, this will take months to resolve. Some people get better quicker, and that's fine, but in terms of managing expectations, it's months, not weeks. We start strong, so cyclosamide or higher dose MMF, but then we maintain with lower doses. Once you're in remission for 6 months and your disease is quiescent, we'll think about you getting pregnant and we will swap your medications appropriately. But you must not get pregnant whilst you're needing cyclosamide or MMF to get you into remission. You mustn't get pregnant when disease is active. And it's a long road and it's a journey we'll go on together. And that's hard. And the other thing that I think I need to remind you about is it's not just all about the immunosuppressants. There's lots of other things that go with having kidney disease. When you have kidney disease, you can be anemic and we can treat that. You tend to have high blood pressure and it's terribly important to treat that. And we know that people with kidney disease are at increased risk of cardiovascular events, particularly later down the road. So we often suggest you need a statin, etc., etc. So from no tablets, it often becomes a lot of tablets, and that's a problem for patients. This is what we call a 1/over creatinine plot. So up here is good function, down here is bad function. Down here is dialysis. This was a patient who was referred to me in 1997 because her creatinine, as you can see, was going up and up and up. It looks like it's going down, 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 it's whatever. She was heading towards dialysis within the year. All I've done in the last 16 years is control her blood pressure. Her lupus has not been active in all that time, but I've controlled her blood pressure, and she's been very good about being party to that. And she has gained 16 years off dialysis. She's nearly about to start. But 16 years, that's a huge gauge. She's been working all that time, she's been well, she's been out and about, she goes home to Jamaica regularly. That would be difficult on dialysis. 16 years, that makes an enormous difference, and that's just blood pressure control. So we don't bang on about these tablets for no reason. What I just want to talk about in the next little bit is new approaches, and our aim is to get rid of the steroids. I think they're the real problem. A lot of the skin changes that I'm sure some of you have are due to your steroids. A lot of the weight gain that people get are due to their steroids. They are the major cause of long-term damage when you look at any cohort of patients with lupus. And over 6 milligrams long-term is the cause of long-term damage. And there is no evidence now for the effect on their own, and there's really very little data on the right dose, except that when people try to use less, patients have generally done better. So we've been asked the question whether you can get rid of the steroids. Other people are also going this way. So there's been some recent publications. This was a group in Germany. They only treat with steroids for the non-kidney bits. So people got bad joint pains, skin problems, etc., etc. And they looked back, and they looked at the patients who had had over 20 milligrams or less than 20 milligrams steroids. And that's quite a big dose. But there was no difference in kidney outcomes over time. They did just as well whether they had the low dose or the high dose. David Jane, who many of you will know, was involved with this study, the Lupus study, which was really a way of assessing myfortic, which is a different form of MMF, whether it was any good. But they took the opportunity to randomise patients either to 1 milligram per kilogram of oral steroids or half a milligram per kilogram of oral steroids. And the patients on half did just as well. Absolutely no difference between them, except the patients who were on half got fewer severe infections and no shingles, that's Oscar, no shingles in the group on the lower dose. So less was better. And then my new favourite colleague is Guillermo Rias Aristosa, still can't pull over his name. He's from Bilbao, he's a lovely guy and he hates steroids. And he has a very interesting regimen that he's been using for a few years now. He thinks methylpred is very safe. So he uses methylprednisolone, which is the intravenous form, high dose, quick and dirty, but tapers down the oral steroids to really low doses relatively quickly. For any of you used to rheumatologists, I used to spend a lot of my time bashing rheumatologists, but rheumatologists use oral steroids. And to get down to 5 milligrams by 16 weeks is quite quick. And he does that. He does actually keep people on 2.5 milligrams of steroids forever. And that is a low dose, I would argue with him, but he does that. And he compared his patients that he's been doing this with the patients who historically they gave much higher doses for. So the hospital he is Bilbao Cruces. And he looked at the proportion achieving complete remission, and this is weeks here, and this is 300 weeks. So as I said, this is over time, over a long time, but he gets to nearly 100% complete remission over a long period of time. So this is going up and up and up and up. The patients who are on the high-dose steroid never actually quite get there. Only about 70% of them get there ever, which is much worse, and this is going out to 1,000 weeks because this is historical. What's more important is the proportion without toxicity. 95% or 90% of his patients on the low dose have no evidence of toxicity, and that's mostly steroid-related side effects, compared to, say, at over 100 months, only about 40% of the high-dose steroid. So an enormous impact on the long-term quality of life by reducing steroids. We took it a bit further. So kidney doctors, also transplant patients, we have a big transplant practice, and in 2005, Hammersmith Hospital, where I've grown up, merged with St Mary's Renal Unit. And St Mary's had a very active transplant programme. And because we serve a large multi-ethnic community in West London, particularly an Indian Asian population, and very prone to diabetes, the regimen they'd been using, which included tacrolimus and steroids, was making people diabetic. And mostly getting diabetic because they were putting on weight. So they took the view, there's been a huge push in transplantation that hasn't happened in lupus, to get rid of steroids. I think it's partly because children are transplanted and steroids are terrible in children, but they've been trying to get rid of steroids in transplantation much more aggressively. And they showed that if you added an antibody, a biologic, and you use a different biologic in transplant, it's a different bit of the immune system you're fiddling with, you could use steroids for 1 week and then just use, initially they used tacrolimus and mycophenolate, but now we just use one biologic called Campac, which is a pretty strong biologic, and just tacrolimus and a week of steroids. And what they showed again was that less is more. Their rejection rates, which is a problem if you've got a transplant, went from 32% to 12%, so much less rejection. New onset diabetes went from 28% to 2%. And that was largely because the patients weren't getting fat after transplantation. And as you know, gaining weight is a real risk. So that was very encouraging. So we also had all been using rituximab. It's an anti-B cell antibody. We thought it worked. We all think it works. It does work. The one trial there's been, which came out after we started this, has been negative, but I could argue about that for a long time, why it was negative. But there was a lot of data, and it's a very safe drug. It's been used in a condition called lymphoma for years, so there's a huge safety profile on it, so transferring it from autoimmune disease wasn't so difficult. So we went bold. We knew, we started as a merged unit, we all hated steroids, we were treating our multi-ethnic community, what should we do? And we thought we'd get rid of the oral steroids. So we have been doing, since 2006, patients get methylprednisolone, they get rituximab and they get MMF if they're not already on oral steroids, and we don't add in the oral steroids. If they're already on oral steroids, we don't increase their dose and we try and wean them over time. You can't just stop steroids if you've been on them for years, because you produce your own steroids in your body, and if you're taking steroids, you won't do that, you'll fall in a heap. So 50%. Some patients do relapse over time, but they haven't had a lot of treatment and they usually respond to redosing. And it doesn't matter what sort of nephritis you've had at the beginning. And I just want to show here, you don't need to know any of the detail, but we re-biopsy patients. If they haven't gone into remission, we offer them another biopsy, because often we show that their kidney is better, they're still just leaking a bit of protein, and over time, they then go into remission, and we don't add in extra treatment. And that's very important, because then we're not over-treating people. Of the 50 patients, there were 5 patients who we switched, because sometimes you just have to, they're non-responders or they've relapsed, and they went on to Lupus and they got steroids. But of the patients who stayed on this regimen, only 2 had significant doses of steroids. One, we tried, she had bad pericarditis with chest pain, it's impossible to get her off, she started steroids, she couldn't get them off. She did get down to 1 milligram, then she got pregnant, I never changed anything in pregnancy, so she went through pregnancy on 1 milligram, and now she's 3 months postpartum and I've just stopped her. So she's off the steroids. And another patient had skin disease and skin flares, and we gave her short courses, and we say this is a short course, we'll stop them in 2 weeks, and that works. So that's quite impressive, because no one has systematically tried to do this. What does this look like in reality? Well, this is Lay. She's a 26-year-old student. Very sadly, in 2007, she lost a baby with severe preeclampsia and thought to have lupus. So she came to us in 2008 with really nasty lupus, affecting her joints, her skin, her blood, and her kidneys. She wasn't on any treatment, so we didn't give her any oral steroids. We gave her our regimen. She responded by 18 weeks, and she was in complete remission by 34 weeks, and has been so since 2009. She had 1 flare in her blood, and we just treated that with methylprednisolone and rituximab, where the standard would be to give her oral steroids. She had a biopsy before she got pregnant because she wanted to ensure that she was in remission, and she was. She switched to azathioprine. She had a planned pregnancy, and it went really well. This is lovely on that here. And she's planning the next pregnancy. And we've even treated flares of lupus nephritis in pregnancy without steroids. So, you know, we've got a lot of patients who've never been exposed to steroids. Now, the problem is that we have to do a trial. I say it's a problem because it means that half the patients in the trial are going to get steroids. But we're one centre, we're doing this locally. You've got to say this is a safe treatment to do generally, you've got to do it in multiple centres, and you've got to do it as a trial. We're doing the rituximab trial. Hopefully it will actually, we've got ethical approval now. I'm the chief investigator, there's lots of people involved. You'll recognise some of these very eminent rheumatologists. And it's multi-centre, focused in the UK, but with EU sites in the USA, and the primary endpoint will be kidney response at 1 year. And what we're going to try and say is that this regimen, without steroids, with rituximab, if it is as effective as a steroid-based regimen, but safer, because we predict it will be safer, then people will switch in countries that can afford to use the treatment. We would argue that the cost saved from the lack of steroid damage is very important. So everyone will be followed for 2 years, because you need to see safety signals over 2 years, and up to 4 years, and we'll look at quality of life. And we've got some money, we're hoping for some more. And just very briefly in the last few minutes, pregnancy and lupus nephritis. And the key message here is please plan. Your doctor should be raising this, but you should be raising it as well. If you've had lupus nephritis, that has an adverse effect on subsequent pregnancies, and the worst case scenario is the patient with active disease who gets pregnant when their disease is active, because the chances of a successful outcome are much worse or much lower, and the chance of damage to the kidney are much higher. So we plan, and we plan pre-pregnancy. I have a long-standing interest in renal disease and pregnancy, and I run a renal antenatal clinic, and I also run a preconception counselling clinic. And we consider all sorts of things. We consider fertility. We talk about being in remission. We screen for antibodies that can be problematic in pregnancy. The most important thing is modifying the medicines and planning those modifications, and things that you need to take as well as things you shouldn't take. There are certain drugs we stop. Some of your blood pressure medicine will change, but you need to have good blood pressure control. We sometimes do a biopsy. You can avoid steroids for flare, and you can breastfeed when you're taking tacrolimus or azathioprine. But these are things you should continue or start if you're not on them when you're getting pregnant. You should be on aspirin. It reduces the risk of preeclampsia. You definitely should be on hydroxychloroquine. I'm going to bang a drum for hydroxychloroquine. If you look at groups of patients on hydroxychloroquine and groups of patients off hydroxychloroquine regardless of pregnancy, those on hydroxychloroquine live longer, have fewer infections, have fewer cardiovascular events. It's a great drug. It's been around forever, and it's licensed for use. But it's very good in pregnancy and it's safe in pregnancy, and women tend to stop all their drugs, and it's such a bad plan because you're very likely to flare when you stop things. Prednisolone is safe, it's inactivated by the placenta. There was a story of cleft lip, but that's in rabbits, it's not in humans. And low dose is probably fine. High doses can, and there are some steroids we give to mature the baby's lungs sometimes for home delivery, and they do clearly positive. But that's fine. Azathioprine is okay. The cyclosporin, we always use tacrolimus, not cyclosporin, but tacrolimus is safe in pregnancy. We're using it more and more as a steroid-sparing agent. I put in brackets non-steroidals, ibuprofen, voltarol, brufen, all those drugs, fantastic painkillers, terrible for kidneys. So I always say, if you've got kidney disease, please don't take them, and you shouldn't take them in the third trimester. You have to stop before you get pregnant. Mycophenolate mofetil, cyclophosphamide, and rituximab, and that's why you need to plan your pregnancies. So that's my last slide. Just to summarise, we need to monitor all patients with lupus to see if they're developing the signs or symptoms of kidney disease, and you really may not know, except for the fact that we dip your urine. If you suddenly get very swollen and puffy, that's a big clue, but you often don't. We need to make the diagnosis, and renal biopsy is an essential part of that. And it does need to be treated. Without treatment, kidney function will be lost. Not all patients respond, and we're looking very closely at what defines a non-responder, but we can change the treatments, and that often works very well. We need to treat for a long time. We need to plan for pregnancies. We need to protect against cardiovascular disease, controlling blood pressure, cholesterol, and protecting the bones. And we need to reduce the long-term risks of the treatment, particularly the steroids. And these are my colleagues, and I particularly want to flag up Tom Cairns. He runs the Lupus clinic with me as a nephrologist, and it was he, when we decided what protocols to do, we said, we could steroid, 2 weeks steroids. He said, oh, just don't give them. And he was right. Thank you very much. Happy to take it. I appreciate you making work.
With regards to the hydroxychloroquine, I have 2 colleagues who also suffer with lupus, and apparently there's been toxicity problems in terms of the eyes with the hydroxychloroquine.
There is a risk, there's a theoretical risk of damage. There can be deposits in the back of the retina around the macula, which is to keep it for vision. There's 2 things. One is, if you read normally at baseline, the guidelines say you don't need to check for 5 years. I tell everyone go for an annual eye check where they look at the back of their eye. There's no problem. The earliest detection is abnormalities in colour vision. So actually, if you're doing it in our, there's a chart and you think, oh, that's a bit wobbly, that's fine. We've just started at Imperial measuring the hydroxychloroquine levels, and we hope in time we'll be able to give more advice about perhaps getting the doses down. It is a theoretical risk. I can think of 1 patient out of several hundred who's probably had it. People do get very unduly worried about it. Can we have any lights up?
Hi Liz, I'm actually under Dr. Tom Cairns as well, so I equally bang the drum in as well. I just wanted to ask you 2 things. Number 1, about the trial that you're planning to do, whether you're selecting people just from their records or whether you want volunteers. And also secondly, just about long term. Obviously you've talked about the fact that it is a long road, and that is very apparent for those of us that have it. We know that, we feel that. Long term, as people get into like their 50s, 60s and beyond, what do you see kind of the road ahead with regards to treatments?
Okay, so 2 things. So the trial is not recruiting yet. We've got ethical approval. I can't tell you how many steps we still have to go down. We took Roche to buy the drug, we're signing the contract. I would hope that we will be recruiting, certainly in the UK and certainly in Imperial, by September. I might be optimistic, don't quote me. We will be looking for people, we will pull people who come with active lupus nephritis who have not been on steroids for more than 4 weeks at that time when they present. So we will be looking, but what I'm very keen as to people patient groups are aware, there's lots of units who look after patients with lupus nephritis, and they should be saying, am I suitable for this trial? And they can happily be referred to us, or their doctors may be being involved. So it's not active yet. Believe me, we'll send out obviously via Lupus UK, I think, when it is. Oh, and long term?
Yes.
So, okay, lupus is a disease that's supposed to get quiescent over time. We become post-menopause that should be becoming more quiescent. So the art is to get to that point, and it does generally get quieter in terms of it, but the art is to get to that point with minimal damage. So it's less common to have flares. We do see, I mean, I've had elderly white men with bad lupus presenting for the first time in their 70s. So it's an average, it's not an absolute. You have to be slightly more careful with treatment in the older patients. I think what you should be watching at, if somebody's been in remission for a very long time, we should be thinking about weaning off medications. I wean off the steroids and then the MMF or the ASA. Other places tend to wean off first and then wean off the steroids. But it's over time and keeping a close eye to check they're not flaring.
Is it worth looking at some of the therapeutic dose of the inflammatory? Is it and the other side was the 22 left.
That's what I said.
I was in certain stuff, and I was reading off, over the year, first year. And January, a couple of December, I was an aspirin, and I was decreased to 50, and it's not
So it would be videos for me to comment on individuals, but what we would do is look at the activity. So some people's antibodies go away, but I think in those it's relatively safe to stop. In those who've still got quite positive antibodies, I tend to do it very slowly, and I would treat for a minimum of 3 years these days, and probably around 5 years opposed to last 11. So quite a long time. You're not going to get that.
Okay, we've got one last question.
Yeah, I noticed that you haven't mentioned methotrexate. Methotrexate not being used in terms of...
Doesn't treat kidneys. So we're interesting as nephrologists, we almost never use it, because once the kidney functions below a certain level, you can't use methotrexate, it's dangerous. It is very good for joints. What we've been tending to do, because we've treated the kidney disease, we're swapping people to methotrexate when their joints are problematic and the MMF might not be holding them. We have then seen people flare with their kidney disease on the methotrexate, so it's a bit of a roundabout, but it doesn't treat the kidney disease. That I'm pretty sure. There's very little data, but I'm pretty sure it doesn't.
So another question I wanted to ask you is, Benedicta actually being used by some people with lupus?
Yeah, no, it is. It's not been used very much because they don't want to pay for its technical problem. So rituximab's not licensed, and we can use it. There is now NHSE guidance on how to use it. The traditional way you're supposed to use it is when you've not responded to MMF or cyclosamide, then you get paid to use rituximab. We use it in a different way, Imperial. But Benedicta, very few people are using because it's so expensive and we don't quite know how to use it. And the trials were all for muscle and really for musculoskeletal and skin. They weren't for renal. There's a hint they might be good for renal, but it's not where it's been. There is a trial going on using it in lupus nephritis, but that's going to be 3 or 4 years down the line before you'll know if that's right.
Well, thank you, Dr. Lightstone, for that very informative talk. Don't forget, John and Margaret are still down the front with all their creams and ointments and things. If you want to come and ask questions, they'll be here for a few minutes. Thank you very much for coming along. I hope you've enjoyed the afternoon. And I understand it's quite warm outside, so enjoy your journey home. Thank you. Bye-bye.